Good morning, everyone. I'm Dr. Abdul Alkaddour, consultant cardiologist, and I want to welcome you all for this beautiful Friday morning. And we have 4 elegant speakers. I will start introducing the first speaker, Dr. Wonjae Lee. Dr. Lee is Associate Professor, International Healthcare Center, Division of Cardiology, Department of Internal Medicine and External Affairs Department, Seoul National University, Bandang Hospital, South Korea. Dr. Lee has experience 17 plus years. We are lucky to have him to talk to us in the next 20 minutes or so on recent update on dual antiplatelet strategy for PCI patients. Dr. Lee, the floor is yours.
My name is Wonjae Lee from Seoul National University, Bandang Hospital. I'm an interventional cardiologist, and it's my honor to be here today. I'm going to talk about recent update on DAPT strategy for PCI patients. I have nothing to disclose. So I'll start with short DAPT strategy for high bleeding risk and move on to DAPT for high ischemic risk. And I'll introduce some of recent trials with new P2Y12 inhibitors. So more patients are at high bleeding risk for bleeding nowadays. They are older, they have a CKD, patients are long-term NSAID use, they're undergoing non-cardiac surgeries, and patients have atrial fibrillation who are using DOAC. AHA made a definition for high bleeding risk, and you can see that some of the features I just introduced, and in addition, their liver disease, active cancer, anemia, low platelet count. And these patients make up actually 40% of all the PCI patients we are doing right now. We all know that mortality after occurrence of bleeding is very high, and in these cases, shorter DAPT is actually associated with lower risk of death. So there has been many short DAPT trials starting 2019 and continuing on. Actually, there was a TICO trial, host-rigid polytech trial, which was scheduled to end in 2023, was actually published in 2020, and I'm going to introduce them later on. So this is one of the landmark studies which studied safety of 3 months DAPT for PCI patient. Patients were all comers, and 32% had ACS. And there was giants using a strategy and DAPT for 3 months. So what we saw is that the only event rate was less than 3%, which is much lower than expected event of 6.6. And more importantly, at 1 year follow, there was no definite or probable thrombosis, even if we had a 3 months DAPT strategy. And there was a smart choice trial, which was done in Korea. Also, all-comers trial, and among them, ACS was about 58%. The trial was using various types of secondary stents, and that for 3 months versus 12 months. And as you can see that there was no difference in composite of events during this 12 months. And as expected, if we use longer DAPT, there is more event with bleedings. And there was STOP DAPT trial, which evaluated safety of 1 month DAPT. It was also all-comer trial, and 38% of patients were ACS. And as you can see that in this case as well, there was no difference of composite outcomes whether patients are 1 month DAPT or 12-month DAPT. And of course, if patients are on 12-month DAPT, they have more risk of bleeding. I just want to note one thing. All the patients actually had an IVUS examination, which actually optimized all the PCI procedures. However, I think we still have situations that we need for prolonged DAPT or more potent antiplatelet agent. ACS, heavy calcification, left main disease, bifurcation, patient's diabetes. Can we actually still just use 1 month DAPT? So there was a trial called SMART DATE, which was also done in Korea, and it looked at safety of 6 month DAPT in ACS. 100% ACS and 70% was MI. So basically evaluating 6 month DAPT strategy versus 12 month. Although there was no difference in MACE, but if you look at only MI, there was definitely difference. After 6 months, there was actually more increase in event of MI, which tells us that maybe for very high risk patient, 6 months or shorter DAPT strategy may be dangerous to patient. And there was ideal left main, which evaluated 4-month DAPT strategy. Well, this trial have some controversy because it was evaluating, comparing Synergy and Giants at the same time, 4-month DAPT strategy with 12-month DAPT strategy. If you look at the result, well, there was no stent thrombosis between 4 and 12 months. However, with Synergy stent, there was a couple of 4 events with definite or probable stent thrombosis, so which give us still some concern that in left main disease, maybe shorter depth may be dangerous to patient. There was meta-analysis having evaluating duration of depth after complex PCI. There was a patient-level pool analysis and optimized, excellent, prodigy, all the trials that you all know. And components of complex PCI were 3 best treated or more than 3 stents, bifurcation or very long lesion, or CTOs were included. As expected, people who underwent complex PCI had much more event. It was more than twice, but there was no difference in bleeding. And what are high-risk procedure subset? Well, all of them have a higher risk, but among them, 2-stent strategy at bifurcation had highest risk for ischemic risk. So in these patients who are undergoing high complex PCI, so if patient have no features complex PCI, 12 DAPTs or 6 DAPTs, it doesn't really matter. However, if patient have 1 or 2 or even more features or for ischemic complex PCI features, definitely 2-month DAPT strategy favors patient. This is also a COBIS registry, which is a coronary bifurcation stenting registry in Korea. And in this study, we evaluated DAPT more than 12 months and less than 12 months. And you could, the result, if patients were under 12-month DAPT strategy, you can clearly see that after 1 or 2 years, there may many more events happening, cardiac death, MI, or stent thrombosis. Again, telling us that if patient underwent bifurcation with a 2-stent strategy, maybe patient might need more prolonged DAPT. And this is result of Grand DES registry, which evaluate left main bifurcation. So patient was divided to 2 groups who had underwent left main bifurcation PCI, 1 stent strategy and 2 stent strategy. If you look at the result, if we use DAPT for more than 1 year, it doesn't really matter patient had 1 stent or 2 stent. However, if patients are under DAPT for 12 months, there's significant difference between 2 groups. So patient had 2 stent, and if they had a less than 1 year of that, there's significant increase in target failure or thrombotic-related adverse cardiac events. Now I'm going to move on to clinical trials with new P2Y12 inhibitors. So there was a trial, with Twilight trial, which evaluated high-risk PCI patient using Giant stent, and it was comparing 3 months DAPT versus 15 months DAPT, and actually was comparing ticagrelor single strategy with ticagrelor plus aspirin. If you look at the baseline demographics, patients were about 65 years old. There was about 35% of diabetes patient, and CK 16%, and ACS presentation was 64, which was quite high. And multi-vest CAD was 63%, and total length was 40 millimeter, which was also a high-risk feature. So if you look at the primary endpoint, which was BARC 2, 3, or 5 bleeding, yes, there's significant difference between ticagrelor aspirin versus ticagrelor alone. Yet, however, even if patient on just ticagrelor single compared to ticagrelor plus aspirin, there was actually no difference in death, MI, or stroke, which is telling us that with newer, stronger agent, we might have a shorter DAPT duration, but still managing ischemic risk. Recently, it was, I think last year, there was 2 landmark studies for different strategies for P2Y12 inhibitors were introduced. One is TICO trial, which evaluated ticagrelor monotherapy versus ticagrelor plus aspirin in Korean ACS patients. So what was done was that patient was on that for 3 months, ticagrelor plus aspirin, And then after 3 months, one group maintained this DAPT strategy, but one group dropped aspirin and maintained only ticagrelor. So if you look at the left side, 12 months clinical outcome, there was actually significant difference between longer DAPT versus shorter DAPT. And of course, after 3 months landmark analysis, there was significant difference. Where the difference coming from? So primary endpoint was actually composite of MACE and TIMI major bleeding. So the major difference was coming from actually bleeding. If you look at the left side, there was 87 risk reduction if we use shorter DAPT in major bleeding. However, there was actually no difference in ischemic endpoint, and there was no significant difference in statistically. However, you look at it, there was actually numerically more events with 12 months DAPT strategy versus 3 months DAPT strategy. And this result was reflected in ESC guideline in 2020. So if you look at the non-ST elevation ACS patient, if patient have a low risk of bleeding, patient can have aspirin and ticagrelor for 3 months and move on to ticagrelor single strategy. Next is that prosecutor-based de-escalation of DAPT after PCI, which is called host-reduced polytech ACS trial, also done in Korea. So there was a two group. Prosecutor 10 milligram was maintained for 1 month, and after 1 month, one group was randomized and de-escalated to prosecutor 5 milligram, and the other group was prosecutor 10 milligram throughout the year. And result was that this study also looked at NACE, which is net adverse clinical event, and as expected, there were much more events with conventional strategy compared to de-escalation strategy. De-escalation strategy had only 7.2% event, whereas conventional had a 10.1%. And key secondary outcome, which was efficacy outcome, look at it, there's no difference. And again, numerically, de-escalation strategy actually had a less event compared to conventional strategy. And of course, if we look at the safety outcome only, there was significant difference between de-escalation versus conventional, which had a 10 milligram throughout the year. And there was one more group, which was observational, since prosecutor had indication, does not have indication for people older than 75. And it seems that there was much more event in observational group as well, telling us that we might need to have a new strategy for these patient subset using this kind of new P2Y12 inhibitor as well. So my take-home messages are, we should now definitely apply shorter DAPT strategy for patients with high bleeding risk. And to do that, we have to simplify PCI and minimize meta burden for these patients if they have high bleeding risk features. And of course, there are still patient subset who has high ischemic features that still mandates longer DAPT. And shorter DAPT duration or de-escalating strategy with new P2Y12 inhibitors might give us some solution to mitigate this kind of patient who has high risk at the same time with high bleeding risk. Thank you for your attention.
Thank you so much, Dr. Lee, for a wonderful presentation. We're going to keep the questions towards the last. We have 3 more talks to listen to. And our next speaker, Dr. Wonjae Lee. She's medical professor at Department of Cardiology, Seoul National University Hospital, South Korea. She has experienced 9+ years. She has completed a PhD in internal medicine at Seoul National University College of Medicine. She has published many theses, being the first author. Dr. Lee is going to talk to us about a very complex and very important subject, which is multimodality imaging in valvular heart disease. So we're waiting for the presentation shortly. Thank you so much.
Dear ladies and gentlemen, my name is Wonjae Lee, and I am honored to be invited here. Today, my lecture is about multimodality imaging in valvular heart disease, and it's a rather broad theme, and I am going to focus mainly on aortic stenosis, in which multimodality imaging has an important role. While echocardiography is the cornerstone of diagnosis and follow-up in valvular heart disease, other imaging modalities can also provide complementary and additional information. And today I am going to talk about that. This is the contents of my talk. I am going to talk about the diagnosis, progression, risk stratification, the detection of comorbid disease, and planning TAVI in severe AS, and then touch on the use of CMR in valvular regurgitation. First of all, as you well know, there is often a discrepancy of echocardiography parameters for grading the severity of aortic stenosis. While the pressure gradient is inversely proportional to valve area, there is a gray zone in which patients have a valve area of under 1 square centimeter, but a mean pressure gradient under 40 millimeter mercury. And these patients can be classified as low flow, low gradient severe AS. The American guidelines further divide symptomatic severe AS into classical high gradient severe AS and low flow, low gradient severe AS. The low gradient is due to low flow through the valve and thus the term low flow, low gradient AS. Low flow can be caused by two reasons. The first is reduced LV ejection fraction, and the second is low stroke volume due to a small LV chamber. This latter is called paradoxical low flow, low gradient AS with a normal LV ejection fraction, and this is often confusing to diagnose in the clinical setting. And this is a diagram of normal severe AS, while this is a diagram of a paradoxical low flow, low gradient AS with a small LV chamber. This is the European guideline for diagnosing severe AS. If there is a high gradient, which is not secondary to a high flow status, then no problem, severe AS can be diagnosed. However, if there is a low gradient with a Vmax of under 4 meters per second and a mean pressure gradient of under 40 millimeter mercury, although the AV area is under 1 square centimeter, it is difficult to decide whether the patient has severe AS or not. In this case, first, whether the low gradient is due to a low flow should be assessed. In the routine echocardiography exam, this can be calculated with the LVOT Doppler. If the stroke volume index is greater than 35 millimeters per meter square, then severe AS is unlikely. However, if the stroke index is less than 35 and the low flow is due to reduced LV ejection fraction, then a dobutamine stress echocardiography should be done. If there is low flow but the LV ejection fraction is normal, then many other clinical and imaging data can be checked to see whether they fit the paradoxical low flow, low gradient AS picture. In this case, an important additional imaging modality is the AV calcium score by CT. So these two are the important additional imaging modalities to make the diagnosis of severe AS in the context of low flow, low gradient AS. The dobutamine stress echocardiography should be done for low flow, low gradient AS due to reduced LV ejection fraction to check whether an increase in stroke volume results in greater opening of the aortic valve. If the aortic valve stays below 1 square centimeter, even though the AV Vmax increases to over 4 meters per second, then the patient can be diagnosed with severe AS. However, if there is no flow reserve and AV Vmax does not increase despite the administration of dobutamine, then it is difficult to make a diagnosis. In this case, and in the case of paradoxical low flow, low gradient AS with preserved LV ejection fraction, the AV calcium score by non-contrast CT is useful. Advanced calcification strongly suggests severe AS. There are gender-specific cutoffs for diagnosing severe AS. As stenosis plays a greater role in women, the cutoff value for calcification is lower in women. The AV calcium score also strongly predicts future hemodynamic progression and has an independent prognostic value over echocardiography. This is an example of AV calcium scoring by non-contrast CT. The first patient has mild AV calcification and an AV calcium score of 200 Agaston units. On the other hand, the third patient has severe AV calcification with an AV calcium score of 2,000 Agaston units, which is above the threshold for severe AS. Severe AV calcification was also independently predictive of death and AV replacement in patients with AS. Next, the PET may have a role for predicting AS progression. Radio-labeled sodium fluoride has a strong affinity to microcalcification and thus can be used to measure calcific activity even in the absence of visible calcification on standard CT. Thus, the sodium fluoride PET visualizes areas of valve degeneration which are predisposed to progression to calcific stenosis. In this figure, you can see intense sodium fluoride uptake which are adjacent to the pre-existing calcification of the aortic valve. And 1 year later, on a follow-up CT, you can see that extensive further calcification has developed in the areas of strong sodium fluoride uptake in the baseline PET. Currently, the PET-CT is mostly used for research purposes, but in the future, it may have a role in identifying patients at risk and also targets for novel drugs. Next, currently, the only treatment for aortic stenosis is aortic valve replacement, and thus the timing of intervention is a very important decision. In the latest guidelines, the timing of intervention is largely guided by the development of symptoms or the reduction of LV ejection fraction to below 50%. Otherwise, AV replacement can be considered in asymptomatic patients with abnormal exercise result tests or very severe AS or rapid disease progression, but these recommendations come with a lower grade. However, the problem with these guidelines is that the symptom status is notoriously subjective in severe AS. Also, the decrease in LV ejection fraction usually occurs at a late stage after the LV has developed irreversible damage. Thus, aortic valve surgery in patients with reduced LV ejection fraction is associated with higher operative risk and worse postoperative outcomes. Thus, there is a need for imaging biomarkers to detect LV damage before it is irreversible and thus make timely intervention possible. This is the process of how aortic stenosis progresses and LV decompensation develops, and the imaging modalities that can help visualize the stages in this process. As aortic stenosis progresses, LV hypertrophy and interstitial fibrosis develops, along with cell death and replacement fibrosis, which lead to diastolic dysfunction and then systolic dysfunction and heart failure. The symptoms and reduction in LV ejection fraction occur only late in this process. However, cardiac MRI can image the extent of myocardial fibrosis before the symptoms develop. And also, global longitudinal strain assessment with speckle tracking echocardiography can find LV systolic dysfunction before overt dysfunction by LV ejection fraction. Thus, these imaging modalities are useful for detecting LV decompensation before the onset of overt symptoms in heart failure. First, the speckle tracking echocardiography can be used to measure global longitudinal strain, which is a sensitive marker of LV dysfunction. Thus, it is useful in asymptomatic severe AS patients with preserved LV ejection fraction. Reduced LV global longitudinal strain was associated with increased risk of symptom development and also mortality. However, the limitation of strain is that there is a lack of standardization between vendors and that there is an overlap in values between healthy and diseased states, which makes it difficult to establish a cutoff value. Reduced LV GLS was associated with increased risk of symptom development and also aortic valve intervention. Also, even patients with normal LV ejection fraction showed worse survival if they had impaired LV GLS. and these patients showed no difference in survival with patients with impaired LV ejection fraction. Thus, the LV-GLS can be used to discriminate high-risk patients within patients with preserved LV ejection fraction. Results of a large-scale meta-analysis also supported the association between impaired LV-GLS and poor outcome, especially in patients with normal LVEF. And cardiac magnetic resonance imaging can directly image the fibrosis and scarring of the myocardium. Myocardial fibrosis can be categorized into diffuse interstitial fibrosis and focal replacement fibrosis. This diagram shows the composition of the myocardium consisting of the cells and the matrix. In the matrix, there is fibrosis and also focal scar change. With the CMR, late gadolinium enhancement visualizes replacement fibrosis, in other words, the scarred myocardium, while T1 mapping and ECV visualizes the whole extracellular matrix. LGE is a marker of replacement fibrosis, which was validated with histology in previous studies. Once established, LGE accumulates very rapidly, and aortic valve replacement can arrest the development of further LGE, but it cannot reverse the already established LGE. LGE is an important predictor of all-cause mortality, even after AVR. And all LGE patterns, either non-infarct or infarct LGE, were associated with worse survival. This suggests that AV replacement before the development of significant LGE can be beneficial. T1 mapping on CMR is useful to image the diffuse interstitial fibrosis in the myocardium. Native T1 can be measured on MRI without the use of gadolinium-based contrast agents. However, there is substantial overlap between diseased and healthy states, and T1 values can be affected by technique and field strength, which is a barrier to be used in multi-center studies. The native T1 was correlated with a degree of diffuse fibrosis on histology. An increase in native T1 was associated with worse clinical outcome, both before AVR and after AVR, and also regardless of whether the presence of LGE. The extracellular volume fraction is calculated using native T1 and post-contrast T1 values of the myocardium and the blood pool, and also the hematocrit. Conceptually, the ECV corresponds to the extracellular matrix and is a marker of diffuse myocardial fibrosis. The calculation of ECV potentially corrects for differences in T1 values caused by different scanners and sequences, and thus is a more robust parameter that can be used in multicenter studies. To calculate ECV, concomitant blood sampling for hematocrit is needed. Higher ECV values were an independent predictor of mortality. After AV replacement, while this is the replacement fibrosis and this is diffuse fibrosis. After AV replacement, while replacement fibrosis does not regress, you can see that diffuse fibrosis is observed to regress over time. Currently, many randomized controlled trials are ongoing to investigate whether early intervention is beneficial in asymptomatic severe AS. And most of the studies enroll all-comer severe AS patients. One of these trials is the EVOLVE trial, which is enrolling patients with LGE on CMR. And the results will show us whether risk stratification with CMR will be useful to decide whether early intervention in asymptomatic patients with severe AS is beneficial. Multimodality imaging techniques can also be used to detect comorbid disease in aortic stenosis, specifically cardiac amyloidosis. Recent studies are showing us that there is a high incidence of hidden cardiac amyloidosis in severe AS and should be suspected in patients with low flow, low gradient AS, excess hypertrophy, low ECG voltage, higher troponin or NT-proBNP levels. One recent study showed that 13% of the patients over the age of 75 who were referred for TAVI with AS had ATTR cardiac amyloidosis, according to bone scan results. TAVI improved outcomes in severe AS patients with ATTR amyloidosis as well. To detect cardiac amyloidosis in AS, CMR and bone scintigraphy are useful. On CMR, cardiac amyloidosis is associated with typical LGE patterns of marked myocardial enhancement, either subendocardial or transmural. Of course, there is a wide variety, and some patients, especially with early amyloidosis, may not show LGE. T1 and ECV values are also prominently elevated in patients with amyloidosis. And here are some examples of LGE patterns in amyloidosis. You can see patients with no LGE, and also patients with subendocardial LGE, and also patients with transmural LGE throughout the whole myocardium. And this is the same. You can see subendocardial LGE and whole transmural LGE uptake. The bone scintigraphy is a very accurate modality to diagnose transthyretin amyloidosis. 99 technetium-labeled bone-avid radiotracers are used. Currently, 3 types are in use: PYP, DPD, and HDP. To note, MDP is often used in bone scans but has low sensitivity for cardiac amyloidosis and is not recommended for this purpose. Any cardiac uptake on bone scintigraphy was over 99% sensitive and over 86% specific for ATTR amyloidosis, with false positive almost exclusively limited to AL amyloidosis in one study. Thus, bone scintigraphy is becoming the diagnostic test of choice for ATTR amyloidosis. The degree of cardiac uptake is usually graded semi-quantitatively using the Perugini score of grade 0 to grade 3. Grade 0 is no uptake. Grade 1 is mild uptake less than the rib. Grade 2 is uptake similar to the rib. And grade 3 is strong uptake more than the rib. Also, the uptake can be graded in a quantitative score in contrast to the rest of the bone. In planning the TAVI procedure, the CT is the gold standard for the assessment of the aortic annulus, root, aorta, and peripheral vasculature for access. We no longer use the TEE for pre-procedural planning in our hospital. And I'll show you an example of how the CT is used for TAVI planning. This is an ECG-gated thoracoabdominal aorta CT angiography scan of a patient with severe AS. You can see the whole aorta in this scan, and also each of the femoral arteries for peripheral access. The abdominal aorta and the aortic arch are inspected in detail for any significant stenosis or calcification. Next, the aortic annulus is measured. And then the LVOT is measured. And the aortic valve calcification is assessed. You can see a calcified chunk in the NCC. And then the coronary heights are measured. The ST junction is measured. And the best valve implantation angle is planned according to the alignment of the heart on the CT. You can see the recommended angle is around LAO 30. All of the above information is summarized in this table. According to these measurements, the SAPIEN 3 valve 23 millimeter size is recommended for this patient. And alternatively, the Evolut Pro 26 millimeter size can also be used. And then the peripheral vessels are checked again to see if there is any stenosis and any expected problems with the valve passage. Lastly, the diagnosis of severe regurgitation is sometimes difficult to make by echocardiography. In this case, you can use the CMR as a complementary modality to quantify valvular regurgitation. The phase contrast velocity encoded MRI, which is abbreviated as VENC in our hospital, is used for this purpose. One point to keep in mind is that the cutoff values for severe regurgitation are different for echocardiography and CMR. The CMR-derived regurgitant fraction cutoffs are lower. You can see that the cutoff is around 40% for severe regurgitation in CMR compared to 50%, which is usually used in echocardiography. In the phase contrast MRI, slightly different techniques are used to measure regurgitant fraction for AR and MR. In AR, the regurgitant fraction is quantified directly through plane phase contrast analysis at the sinotubular junction level. On the other hand, in MR, the LV stroke volume is calculated from volumetric analysis, and then the aortic stroke volume is measured from through-plane phase contrast analysis, and then the regurgitant fraction is calculated from these values. So today I show you the use of multimodality imaging in valvular heart disease, mainly aortic stenosis. The DSC and the CT-AV calcium score is useful for the diagnosis of severe AS. The sodium fluoride PET-CT is useful for predicting AS progression. Speckle tracking echocardiography and CMR are useful for risk stratification of asymptomatic severe AS. CMR and bone scintigraphy can provide the diagnosis of cardiac amyloidosis in AS. And in planning TAVI for AS, CT is a valuable modality. And where echocardiography is inconclusive in valvular regurgitation, CMR is a valuable modality. And thank you for your attention.
Thank you so much, Dr. Lee, for a wonderful presentation for such complex subject. And we move on. I think we are ahead of our schedule. We can use the time towards the end for the question and answers. Our next speaker is Dr. Jong-Il Choi. Dr. Choi is Professor, Division of Cardiology, Department of Internal Medicine at Korea University, Annam Hospital, South Korea. He's an electrophysiologist. He has experienced 23 plus years. He has achieved so many awards, the most recent of which is Best Research Award of SIGTOP Korea University, Seoul, Korea. And Dr. Choi is going to talk to us about a very important subject, which is sudden cardiac death and inherited arrhythmias. Okay, Dr. Choi, the floor is yours.
I am Jong-Il Choi, professor of Korea University. I am a cardiologist in Korea University and section director of cardiac electrophysiology and arrhythmia service, Korea University Annam Hospital. Nice to meet you. Today, my topic is sudden cardiac death and inherited arrhythmia syndrome. I would introduce an interesting case. Female, 57 years old patient. She experiences adverted sudden cardiac arrest at the swimming pool. Fortunately, she recovered by CPR and AED, and so return of spontaneous circulation was performed by witness, and she was referred to our hospital. And immediately after referring our hospital, we managed her, and within the first 24 hours, in the hypodermic therapy, and simultaneously we performed the evaluation for cause of sudden cardiac death, including transthoracic echocardiography and coronary angiogram. And also we collaborated with the neurologic department for evaluation of brain status, the EEG. So a patient is good. And after recovery, we was investigated in the cascade screening and cardiac evaluation, including coronary angiography and echocardiogram, and treadmill test, and the drug challenge, and for the adrenaline and procainamide test, and imaging test, and the CT and cardiac MR, and also we checked the genetic testing in this patient. Her ECG showed in the QT prolongation, and also we can diagnose in the long QT syndrome in this patient without any overt heart disease. And we decided to ICD implantation in this patient in addition to use of beta blocker in order to prevent the sudden cardiac death. And I would introduce in the spectrum and of the epidemiology of sudden cardiac death. Sudden cardiac death is an emerging issue, and so this is a very famous figure. And similarly with the previous patient and the high-risk subgroup patient, the arrhythmic risk is higher and hemodynamic risk higher. And however, the proportion of this patient among the general population relatively low. But in the general population and the moderate to lower risk patient group showed low risk, but proportion of sudden cardiac death risk is very high. And so first, we need the focus in this population in the public health in order to reduce in the sudden cardiac death rate. In the ischemic heart disease, such as acute coronary syndrome, is most important cause of sudden cardiac death. And so 2013, American Heart Association and the American College of Cardiology recommend this risk calculator, the atherosclerotic cardiovascular risk estimator, the 10-year prediction model. And we can use this risk factor in the smartphone app, and sex, age, race, cholesterol level, blood pressure, population. After that, as time goes, the rate of sudden cardiac death dramatically decreased after 5 years, and over 20 years, the hazard ratio is decreased more than half. And so lifestyle modification, including smoking cessation, is most important in the primary prevention in sudden cardiac death. Similarly, in the general population, in the lifestyle modification and the risk stratification is important. However, the patient with the structural heart disease, the myocardial infarction or heart failure, and we need other parameters to predict sudden cardiac death. And so currently, ejection fraction, that is reflect left ventricular function, is most robust risk prediction marker. And so we can use the ejection fraction for the primary prevention for sudden cardiac death. And based on this data and the parameter, we applied in the ICD implantation, transvenous or subcutaneous, to prevent sudden cardiac death, secondary prevention and primary prevention. That is improved survival benefit compared to the conventional therapy. Let's see the cause of sudden cardiac death, especially in inherited arrhythmia syndrome. This is a cause of sudden cardiac death, and shown in the textbook of internal medicine, in the Harrison textbook. Coronary artery disease or ischemic heart disease, most common cause of sudden cardiac death, and especially in the Western country, the 75% to 80% in the male patient. Inherited arrhythmia syndrome is a genetic cause or primary electrical disorder, 1 or 2% in the Western country. However, recent Japanese data reported in the inherited arrhythmia syndrome is exists in the 10%, about 10% of sudden cardiac deaths. And so Asian country inherited arrhythmia syndrome is more important than Western country. Inherited arrhythmia syndrome or primary electrical disorder include the following disorder: long QT syndrome. The QT prolongation is a very pathognomic finding. Brugada syndrome, this is a doctor name. Short QT syndrome, catecholaminoid polymorphic ventricular tachycardia, and early repolarization syndrome, and idiopathic ventricular fibrillation, arrhythmogenic right ventricular cardiomyopathy. This disorder, though relatively rare cause of sudden cardiac death, however, very unique characteristics in the clinical practice. First manifestation is a very severe form, sudden cardiac death or syncope. Early prediction is very difficult. This disorder is genetic or familial disorder, so that this disorder is not curable. Most patients was a young patient, so this disorder have a socio-economic impact, and ICD is the only treatment modality to prevent sudden cardiac arrest. This disorder, the genetic disorder, and in pathophysiologically, genetic variant making the abnormal protein, including ion channel, and some disease in the gain of function of ion channel, or some disorder loss of function ion channel. ALVC is a similar the genetic disorder, and especially the right ventricular fatty replacement in the fibrosis. Clinically, we cover in this disorder in the cardiovascular genetics clinics. ECG is very helpful to diagnose this disorder because the pathognomic finding exists in this each disorder. Long QT syndrome shows QT prolongation and more than half between RR interval. Brugada syndrome is RS-R' pattern and ST elevation and the T inversion. This is a very typical finding of ECG. CPVT is a bidirectional ventricular tachycardia during exercise, soccer play, and the QT shortening. ALVC is a pathognomic finding is epsilon wave in V1 or V2, and just in the 30–40%. And then echocardiogram and the coronary angiography is very helpful to exclude in the structural heart disease, and Holter and the treadmill test and the imaging test. Optionally, we can use the electrophysiologic study or drug challenge test and the implantable loop recorder, and sometimes we can use the genetic testing to diagnose it in this patient. Let's see the each disorder characteristics. First, in the Brugada syndrome. This ECG shows the typical finding of Brugada syndrome. Let's see the V1 or V2 read RS-R' pattern and the ST elevation and the T inversion. This is a type 1 Brugada ECG. We can diagnose the Brugada syndrome only just using this ECG without any other symptom. And however, sometimes we can observe like this finding and the Saddleback type or without T inversion. We can call type 2 or type 3 Brugada ECG pattern. At that time, we can use a drug challenge test. And type 1 is a pathognomic Brugada syndrome. And importantly, we should exclude other causes of Brugada ECG pattern, including febrile illness and hypokalemia and hypodermia and ischemia. Sometimes we can see this ambiguous finding, and at that time we applied V1 or V2, 1 or 2 upper level and the left intercostal space and 2 second or third. Then makes the unmasking finding of Brugada syndrome like this. As I mentioned, the ICD is only treatment modality to prevent sudden cardiac arrest. However, only just to ECG, type 1 ECG finding, at that time, only if the patient experienced the history of syncope, presumably ventricular tachycardia, we can consider ICD implantation. Asymptomatic patient, we should not consider ICD implantation. Next, long QT syndrome. This is a female 90 patient, my patient, unexplained syncope recurrent during sleeping. As you can, if you look at that, the QT interval very prolonged, and clinically we use the Bajen method or Friederichia method in the correction in the heart rate variability in this patient, and 500 milliseconds more over, we can diagnose the long QT syndrome. During the sleeping, patient experienced polymorphic ventricular tachycardia. This is the sudden cardiac arrest status, and we applied in the ICD implantation and the beta blocker use. The patient is stable. And long QT syndrome is a genetic disorder, so up to date, we found more than 20 type of long QT syndrome. However, long QT 1, 2, 3 is 90% is most prevalent disorder. QT prolongation is very important in this patient. More than 480 milliseconds, very pathognomonic in this patient. However, sometimes patients show the normal range of QT interval. Some patients we can diagnose the long QT syndrome. And so genetic testing and other symptoms, including syncope or deafness or family history, is important to diagnose in this patient group. This is a very interesting figure. As I mentioned in the long QT 1, long QT 2, long QT 3, the 90% of long QT syndrome. Long QT 1 or KCNQ1 genetic mutation, long QT 2 KCNH2. This mutation is prevalent ventricular tachycardia occur especially triggered by the swimming or related water activity. And however, long QT2 feeding or auditory stimulation is a very important triggering in this patient. Interestingly, in the long QT syndrome 3, during just the sleep or resting, is a sudden cardiac arrest most prevalent. And also, EKG is very pathognomic to discriminated in this genetic type. Long QT1, broad type of QT prolongation. Long QT2, notch type. Long QT3, just delayed type of QT prolongation. This finding is not absolute finding, but we can triage or apply it in the long QT1, 2, 3 genotype. It may be helpful in your clinical practice. Similarly, with the Brugada syndrome, long QT syndrome also, ICD is a very, very important treatment modality. And prior cardiac arrest, ICD should be recommended. But just only recurrent syncope while on beta blocker, we also recommend ICD, but asymptomatic patient, ICD is not indicated. Some patients very, very refractory condition, even though the beta blocker is relevant to ICD implantation already, at that time, we can consider left cardiac sympathetic denervation to reduce the sympathetic activation. And so this therapy is very helpful, especially in the female patient before the pregnancy. Let's see the other inherited arrhythmia syndrome. This is a very unique ECG finding. Sinus rhythm, abruptly ventricular fibrillation occur. And in this full evaluation showed no any other finding of structural heart disease and genetic testing negative, we can diagnose the idiopathic ventricular fibrillation. Let's see this ECG and the ventricular tachycardia, upward, downward is alternatively shown. This is a bidirectional ventricular tachycardia, and especially occur during sarcopenia in the adolescent patient. And we can diagnose the catecholaminergic polymorphic ventricular tachycardia, and pathophysiologically, the calcium intracellular calcium homeostasis is very important. This is involved in the electrical contraction coupling the cardiac contraction, and the lionel receptor is a main organ in this homeostasis, and the systole, calcium pump out, and via rhinal receptor, and diastole pace, calcium within the sarcoplasmic reticulum. And this rhinal receptor mutation showed some ventricular tachycardia bidirection VT, and we can diagnose the CPVT. Leiden 2 is a very important genetic mutation in this patient. This is ECG also very unique finding. We can see the notch at the end of QRS depolarization, especially in the lead 1 and V4, V5, and this patient in the ventricular fibrillation or ventricular tachycardia occur. And we can diagnose the J-wave syndrome or early repolarization syndrome. And quinidine is a drug of choice in this patient. Recently, mitral valve prolapse is one of the causes of sudden cardiac death, especially in younger female patients. And in patients with mitral valve prolapse, when you observe in the PVC or non-sustained ventricular tachycardia, you should consider the possibility of sudden cardiac death in this patient. Finally, I would introduce the genetic testing in this patient. And genetic testing is maybe helpful to diagnosis in inherited arrhythmia syndrome predisposing to sudden cardiac death. Recent technological advance, especially in the next generation sequencing, NGS, can facilitate the analysis of a broad range of gene faster and lower cost. And so we can use genetic testing in clinical field in this patient population. Recently, also, COVID-19 era, wearable device or smartphone-based some the ICT technology, the monitoring the cardiac status in the ECG monitoring in this patient, and we can apply it in this patient population. And so these emerging digital network or technology can address pathophysiological, clinical, and infrastructural gaps in the sudden cardiac arrest that maybe reduce the incidence rate of sudden cardiac death or the success rate and improve success rate of sudden cardiac arrest and the CPR. Let's summary. First, sudden cardiac death is globally emerging issue in public health. Second, sudden cardiac death can be prevented lifestyle modifications such as smoking cessation, as well as drug use or ISD implantation. Third, inherited arrhythmia syndrome, including long QT syndrome or Brugada syndrome, is most prevalent in Asian country. Finally, in the future, genetic testing using next-generation sequencing and ICT-based technology such as smartphone or wearable device will be helpful to improve or reduce the sudden cardiac death rate. Thank you for your attention.
Thank you so much, Dr. Choi, for such a beautiful presentation. And I really enjoyed all of it, especially when you emphasized on tobacco cessation as one of the important modalities to decrease the prevalence of sudden cardiac death. Now, last but not the least, speaker of today, Dr. Song Seo, is professor of the Department of Thoracic and Cardiovascular Surgery at Samsung Medical Center, South Korea. He's a cardiac surgeon. He has 24 plus years of experience. Dr. Seok will talk to us today about hybrid procedure of atrial fibrillation. He will bring 10 years experience in 20 minutes. The floor is yours, doctor.
Assalamu alaikum. I am Dr. Jung, Dong-Sop Jung, as the main cardiac surgeon in Samsung Medical Center. What I talk about today is the clinical result of hybrid treatment in patients with persistent atrial fibrillation. I would like to thank to the medical profession who had taken the time to attend this webinar. I would hope that this presentation may helpful to you. Here is the quick introduction to Samsung Medical Center. It is an urban tertiary care academic hospital with almost 2,000 beds and over 9,500 outpatient visits per day. There are over 5,000 medical professionals, including doctors, nurses, nursing assistants, and technologists, in addition to over 2,000 non-medical support staff. In normal heart, the regular heartbeat is maintained by sinus node signals. However, in case of atrial fibrillations, the abnormal signals originated from the pulmonary vein orifice. Left atrium and annular structure cause irregular heartbeat with rapid ventricular response. Over time, the heart is going to be dilated, especially left atrium. The left atrial appendage, which is notorious for stroke formation in atrial fibrillation patients, become dangerous due to large thrombus formation. Without left atrial contraction, thrombus formation occurs usually in left atrial orifice. Large area stroke is one of the major complications of atrial fibrillation. There are two interventional treatments for atrial fibrillations. Hybrid procedure collected advantages of two treatments, and the goals are the sinus rhythm maintenance and no anticoagulation, atrial reverse remodeling and minimal invasiveness, and shorter hospital stay. Hybrid procedure consists of thoracoscopic ablation and confirmative catheter ablation. The merits of thoracoscopic ablations are the easy pulmonary vein isolations, the bipolar technique. And epicardial ablation is possible, especially marginal vein division, ganglionated plexus ablation, and superior and inferior lines. And the third is the left atrial orifice resection. The stapling and array clip is possible and very minimal invasive. Currently, minimal invasive Cox-Maze procedure is available in the field of cardiac surgery, but a small incision causing pain, technical demanding, and cardiopulmonary bypass installations are obstacles to minimal invasiveness. This is a totally thoracoscopic ablation in Samsung Medical Center. Only 3 small holes are necessary. 5 mm holes are enough to do ablation. For easy ablation, the lightning dissector and rubber band are used. The posterior dissection is very difficult without these instruments. And then, bipolar clamps are applied, guided by EP instruments. After clamping, the signals are checked. The 6 times can achieve complete transmural lesion. The other side, pulmonary vein isolation, can be easily performed. The posterior box lesion can be easily made with the linear ablator. The left atrial appendage is occluded with a clip. This clip is very safe. And this is the video showing my live box demonstration in 2014. I do the right side procedure first. It's the oblique sinus dissection for luminal dissector passing. The illuminator passes from the oblique sinus to transverse sinus to guide the clamp. The dissection between right pulmonary artery and array loop is confirmed, and the rubber and elastic leader are guided by the illuminator. You can see the pulmonary veins, right pulmonary veins. And the jaws are open and encircles the right pulmonary vein antrum. And then clamp. The pulmonary vein isolations for 30 seconds, 6 times at least. And then I do ganglionated plexus ablation, which are notorious for the recurrence of atrial fibrillation. The GP, ganglionated plexus, usually located in around the IVC, mainly. The inferior line ablation using a linear pen, and superior line ablation using linear pen ablator also performed. And then right side procedure is completed. The exit block test and rapid atrial pacing is checked. Then I do left side procedures. First, I divided the ligament of Marshall and then clamp the pulmonary vein antrum and 6 times ablation. The superior line ablation using linear pen ablation is followed. Under direct vision, I can see the right pulmonary vein insertion site. And then left atrial dissection using the endo-stapler 6 mm. At first, there is no clip. The clip is not available, so I always use the stapler, and residual stump is possible. To enhance the rhythm outcomes, I added SVC circular ablation and linear lesion, which are the part of the conventional Cox-Maze procedures. And sometimes I use the cryoablator to reduce time. In case of huge left atrial appendage, I remove the left atrial appendage with a stapler. Currently, routine use of LA clip may facilitate of left atrial appendage exclusion. Various types are available in the market. The 4 sizes are available. The articulation of clip device is very useful in landing the clip to base of left atrial appendage. This video shows the left atrial appendage clip, so-called Pro 2, which is the currently used. Very easy and very safe to use. After 3 years, the LA clip was well positioned at the LA auricle base. In patients with a previous RFCA history, adhesion around the pulmonary vein and LA auricle could cause bleeding. This video shows the LA loop bleeding after division of ligament of Marshall with ligature device. The massive bleeding. The adhesion located between the pulmonary artery and LA loop. I controlled the bleeding by a mini thoracotomy and 3 stitches. Three months later, after thoracoscopic ablation, the post-procedural electrophysiological confirmation is being performed in patients with atrial arrhythmia, usually 25%. CTI ablation, and pulmonary vein isolation, line confirmed, both. If some residual potential is located, stabilization is added. Touch-up ablation 3 or 4 times, and completion the box lesion. The bidirectional block is always tested. The most of patients who had additional ablation, mitral isthmus block is also performed. Both pulmonary vein isolations are checked using Razzak catheter, and bidirectional blocks are also checked. If residual potentials are detected, the additional touch-up ablations are performed after 3D mapping. If atrial flutter originated from CTI, we did not await for 3 months. CTI ablation is performed as soon as possible. The simple CTI ablation is enough to terminate atrial flutter without the 3D mapping. This mapping shows the residual signal at the ridge of left superior pulmonary veins. And several touch-up ablations are enough to remove them. This patient showed sinus rhythm. Nowadays, I perform the epicardial electrophysiological test during thoracoscopic ablation. After pulmonary vein isolation, entrance block was checked with pen-type ablator and X-block test with pacemaker after cardioversion for sinus rhythm restorations. You can see the signal at the vein right atrium. This is the pulmonary vein isolation. And after that, the entrance block test with the pen-type ablator, and there is no signals in the monitor. This is the completion of entrance block. We published 14 papers on hybrid procedure. This paper is the first Korean hybrid procedure report on a Society of Thoracic Surgery in USA, the represented meeting in the field of cardiothoracic surgery. Among 79 patients, the success rate was 92% at 1 year, which was the 65% at discharge. In 2015, I did not perform loop-line SVC ablation due to a safety issue. We are surprised the high success 1 year success rate nevertheless. We also analyzed the usefulness of post-procedural electrophysiological confirmation using RCT manner. After analyzing 45 cases, we found the early sinus rhythm restoration in the hybrid group, but difference disappeared over time. In the hybrid group, the recurrence type was usually atrial fibrillation. However, atrial flutter was the main in the thoracoscopic ablation-only group. Based on this data, we believe thoracoscopic ablation with atrial flutter treatment is enough to achieve a good rhythm outcome. To elucidate the safety issue, our cardiologist, not me, the surgeon, reviewed my data and organized the early and late outcomes this year, 2021. 265 patients with persistent atrial fibrillation were enrolled. 62 patients enjoyed normal sinus rhythm, and 26% of patients underwent additional touch-up ablation. Total 75% patients showed normal sinus rhythm. Including paroxysmal atrial fibrillation, normal sinus rhythm was observed in over 80% patients. Very rare stroke due to LA auricle exclusion. All patients did not have any sequelae. The post-operative complications decreased after learning curve, about 50 cases. No mortality and low prevalence of pacemaker insertion, pericarditis, and effusion. Interestingly, rare fraying of palsy. Probably direct vision can be the explanation. The thoracoscopic ablation is also effective in heart failure patients. In CASTLE trial, which demonstrated the efficacy of catheter ablation in heart failure, the prevalence of sinus rhythm restoration was only 60%. Our data, including 31 patients, demonstrated 93.5% patients showed sinus rhythm. The left ventricular ejection fraction was improved from the average 40% to 54%. From February 2012 to May 2021, we did 600 procedures and no single cardiac mortality. 82 0.5% patient enjoyed normal sinus rhythm. In conclusion, the hybrid procedure is very safe and show the effective 10-year outcomes. The durable pulmonary vein isolation can be achieved. It can prevent the stroke of using the LA clip. So staged hybrid procedure might be the standard in long-standing atrial fibrillation in Korea. I sincerely appreciate your attention today. Shukran.
Afwan, Dr. Ridwan, for beautiful summary of very important subject with 0 mortality and 82% success. Wow, it's very impressive. Now we move to the question and answer sessions. We have 17 or 18 questions, and I will start reading the questions, and I will encourage the panelists to have brief answers so we'll have time for all the questions in the remaining time. So let me see. First question from Dr. Mano, and probably these two questions to Dr. Wonjae Lee. Is CMR or CT are superior to echocardiography? And the other question, what are additional imaging techniques in patients with limited echocardiographic windows? Go ahead, Dr. Lee. You're on mute, so go ahead.
Just a second.
You're on. We can
Hello.
hear you.
Hi, nice to meet you. Can you hear my voice?
Yes, we can.
Okay. It's a very honor to be invited here. And regarding the question on how CMR and CT compares as imaging modalities compared to echocardiography, I think it's different according to what valvular heart disease you are talking about. Both have different roles. For instance, valvular stenosis can only be graded with echocardiography right now because CMR cannot estimate the transvalvular gradient. However, you can estimate the regurgitant fraction with CMR. So when it is inconclusive to evaluate the severity of valvular regurgitation disease, then you can use the CMR as a complementary imaging modality, and it's you can't say which one is better. And CMR is useful because you can use the CMR to evaluate the myocardium. In addition, the fibrosis of the myocardium in addition to the valve. And the CT is valuable, especially for planning procedures, and especially for TAVI. And then I think it will have an increasing role for planning procedures in the mitral valve, especially in the cases with severe calcification. So the imaging modalities all have a complementary role, and which you will use for which purpose. You have to choose which imaging modality is the best for according to your purpose, instead of saying which is best. I think that would be an answer.
How about the second question, the additional imaging techniques in patients with limited echocardiographic windows?
In that case, a limited echocardiographic window is a very big problem in the clinical practice, especially in people with lung disease. And in that case, especially in patients with valvular regurgitation, as I said before, because you can calculate the regurgitant fraction with CMR, the CMR is a valuable, I think the CMR would be the best modality to check the severity of the valvular regurgitation if the echocardiographic views are too poor. But in the case of valvular stenosis, the transvalvular gradient cannot be measured with a CMR. And so I think the best way would be to perform a transesophageal echocardiography, because you can get a reliable transvalvular gradient of the mitral valve with a TEE. And as for the aortic stenosis, it's rather hard to get a reliable view. But if you do it well in the transgastric view, you can get a trans-aortic pressure gradient. So in the case of valvular stenosis, I think TEE would be a good modality. And in the case of aortic stenosis, the aortic valve calcium scoring CT is very valuable for deciding whether this patient has severe AS or not. So for aortic stenosis, you can also use the non-contrast AV calcium scoring CT.
Thank you so much. Very, very clear answer. The next two questions to Dr. Choi. About first question, how to identify if it's sudden cardiac arrest or a heart attack? That's interesting question. And the second question, what screening, genetic or otherwise, should children for people who parents who died of sudden cardiac death should undergo, if any? So please remove the mask so we can hear your voice clearer. Go ahead, Dr. Choi.
Okay. The first question is the cause of sudden cardiac death and the evaluation. Second question is the genetic testing and which patient is useful in genetic testing, right?
Yes. Yes. If a parent died of sudden cardiac death, I've had two questions. First of all, how to differentiate if it's simply heart attack or sudden cardiac death? I think it's a very broad question. I don't know how to answer it, but
okay.
The expert. And the second one, if a parent died of sudden cardiac death, how do you screen the children?
Okay. First, for the first question, usually in patients with sudden cardiac death visited the hospital. So we first time the management of sudden cardiac death for the after return of spontaneous circulation, and then the evaluation for the neurologic sequelae, and then we evaluated in the cause of sudden cardiac death, and that is different in among the country. As I mentioned, in the Western country, the coronary artery disease is the most common cause, and so in the 80 and the 70%, in the Asian country, the 50 or 60%, and so first time that we should evaluate in the coronary angiography for in order to rule out coronary artery disease. If the coronary artery disease does not exist, we should consider the evaluation for the other cardiomyopathy or channelopathy, and the most common cause is hypertrophic cardiomyopathy and the dilate cardiomyopathy, and the channelopathy, the Longquity syndrome, and the Brugada syndrome. And so that is should be done in the inpatient the situation. And for the second question, and the genetic testing for the children or adolescents, and in patients with the family history of sudden cardiac death, that should be the main indication for the genetic testing. That is the most common inherited arrhythmia syndrome is the Longquity syndrome, and CPVT is in adolescent or the children age. And so we need to focus on the Longquity syndrome and the CPVT. That's the main genetic disorder in patients with experienced sudden cardiac arrest.
Thank you so much. Now, next question, any one of you can answer, which we really hear a lot about it. Do COVID-19 vaccine increase the chance for heart disease or cardiac arrest? So actually, Dr. Choi, you can go ahead and answer.
Yeah. We don't have the definite data, and not yet. And so, we know that many data are reported from the China and the United States and the pandemic area, and so the remdesivir and some kind of hydrochloroquine drug increase the rate of sudden cardiac death or ventricular tachyarrhythmia, maybe due to increased QT interval prolongation, and that that is one of the main cause of the instance of ventricular tachyarrhythmia in patients. However, there is no solid data about the association between the drug, the COVID-19, and sudden cardiac arrest.
Any other panelists have a comment on this question? Okay, if no, we move on, Dr. Chang, another question, which I think very difficult to answer in short time, asking about the possible complications of Brugada syndrome. I guess you already touched on that, but if you want to give very brief answer, please do so.
Pardon, the Brugada syndrome?
Possible complications of Brugada syndrome.
Okay, and Brugada syndrome is also genetic disorder, mainly the sodium channel disorder or calcium channel disorder. And the complication is that is the first manifestation is syncope or sudden cardiac arrest. And however, that the Brugada syndrome is compared to the lung QT syndrome, Brugada syndrome is heterogeneity in the oligogenic disorder, not the Mendelian inheritance. And so, however, in the 20 decades and the 40 decades bimodal peak and instance age, and so most common complication is sudden cardiac death or sudden cardiac arrest.
Okay, I have two more questions for you, Dr. Chong, if you don't mind.
Okay.
First one from Dr. Mohammed Hussein. What is the exit block test for? Exit block test.
Exit block
test. Exit block test. I don't know what it is.
You mean drug challenge test?
Well, the simple, the wording for the question is typed question. What is the exit block test for? Is there such things? I don't know.
I'm not sure that is
very vague question. I agree with you. The next question, can the first symptom of atrial fibrillation be a stroke?
Can
it be?
Yes, and then atrial fibrillation is not, you mean in the Brugada syndrome?
No, in general. Can the first symptom of atrial fibrillation be a stroke? Okay.
Atrial fibrillation is also one of the genetic disorder intervening the cause of sudden cardiac death. However, that is not exactly the inherited disorder because we in the familial case we can call the familial genetic atrial fibrillation disorder. Stroke is one of the main cause of atrial fibrillation, and if the Cardiovascular scoring system and more than 2, sudden cardiac, the stroke risk is increased. And so, as you can said, and the atrial fibrillation, one of the first manifestation of atrial fibrillation. However, in the Cardiovascular score, the stroke risk is higher than maybe one of the sudden cardiac. However, in the clinically, if without any other risk factor, stroke is the first manifestation of atrial fibrillation. That is a possible the clinical situation.
Thank you so much. Question to our surgeon, Dr. Dang Xiao. What is the rate of stroke during or after the hybrid procedure for atrial fibrillation compared to the classic treatment?
Hello, can you hear me?
Yes.
Do you hear me?
Yes.
Yes, so I'm Dr. Zhang. The last two questions is also is for me, I think. Can I ask the last two questions first?
Of course.
Yes, the exit block test is this for using pacemaker. It's the pulmonary vein isolation lesion outside. It's the pacemaker stimulation and cannot through the block line. So the exit block test is the pacemaker test. So the check of the block test. Mm-hmm. The second is the stroke is the first manifestation for atrial fibrillation is the question. I experienced many patients with the first episode of a stroke with the paroxysmal atrial fibrillation. So I think it's possible the stroke is the first manifestation of atrial fibrillation. And the third is hybrid, the atrial fibrillation and management is the benefit of both two classic and the RFCA and surgery and the thoracic ablation. The benefit is, I think, I collected all benefits of all the three procedures, so it can make some the more completeness of atrial fibrillation to normal sinus rhythm restoration, including the left stroke prevention at a layer clip, and the durability of pulmonary vein isolation is very improved using the clipping type of pulmonary vein isolation instrument, I think.
Thank you. Next question, you may answer, or Dr. Choi. What lifestyle changes should be undertaken to help control atrial fibrillation conditions? General question.
Epistyle, I think the alcohol is the main recurrence cause in my experience. My patient who did not drink alcohol have many recurrent episodes of atrial fibrillation after re-drinking of alcohols. And then, yeah, aerobic exercise and including the walk is very beneficial to maintain the normal sinus rhythm.
Okay. Now, next question. Does atrial fibrillation ever go into spontaneous remission?
Yeah, my success rate of a hybrid procedure is about 19% in first years after surgery. So it is not, some patients did not respond even although the completeness of complete hybrid procedures. I think it's some the other cause of atrial fibrillations, including genetics, diabetes, and hormonal imbalance. So, but the benefit of our procedure is the rate control. So I think the rate control is enough to maintain the left ventricular systolic function, and 100% in the stroke prevention with LA auricular clipping. So the other side, carotid end, but the stroke is possible, but the cardiac origin prevention of a stroke is, I think, very perfect, I think.
Thank you. Dr. Choi, question for you. Instead of beta blockers, how much effective of ICD for symptomatic patient of, and what are the risks for after ICD? I mean, can you
yes.
Yes.
Okay, that's a very important question.
Yes.
Especially for the sudden cardiac death and bronchitis syndrome, we need to differentiate it in the indication. And for the maybe that's the bronchitis syndrome, and the beta blocker should be treated is every patient. However, bronchitis type 3, the sodium channel disorder, that is we should be careful for some patients, because that is a beta blocker can aggravate it in the bronchitis syndrome and the QT prolongation and the sudden cardiac arrest. However, the recent data reported and all patients should be treated beta blocker. Most useful and effective beta blocker so far, the Alkaddour is one of the best choice in the expert consensus, because that's the duration. Action time is the very longest. And so if you meet the bronchitis patient who are sudden cardiac death, the longer duration beta blocker should be helpful.
Okay, now question. Is there any case in Korea that post-COVID patient developed cardiovascular disease? Who want to take the answer?
I have not case I have no case.
Yes, I also did not have a case on COVID patient surgery. Yeah.
Okay. Now, our next question. What will be the prognosis if a patient had cardiac block after 10 years of heart transplantation? What are the medical and surgical management?
Heart block?
Yes, somebody who have cardiac heart block after 10 years of heart transplantation.
Oh, heart transplantation is not my territory, but
Maybe Dr. Choi.
A transplantation.
Yeah, cardiac heart block after transplantation, 10 years after heart transplant. Maybe pacemaker.
Some patients, I have experienced in some patients in the heart block and severe refractory heart failure in patients with hypertrophic cardiomyopathy. We consider the transplantation. And however, in the transplantation indication is the heart block is not absolute indication of a transplantation. That is a refractory heart failure, even with the drug or some device and LVAD and the therapy. And that's my answer.
Okay, now question, what is the future of treatment? Well, I think the general question, future treatment of cardiovascular disease. I think we should skip this one. What is, for pain, somebody is asking about pain control after surgery. Do you use, are you in use of other operation system? Again, very vague question. Could anyone help me with the best treatment of partial heart block in some patients with myocardial infarction? I think this is very vague question also. I'm sorry, I have to skip it. Okay, question now. What are all the causes of silent heart attack in age group of 30 to 42? Young patients who have silent heart attack in this young age. Is there any specific causes we think of? We know diabetes, we know female have more silent ischemia. Maybe the same thing applies to this age group, right?
I'll take the lead for answering the question. So I think definitely in that age, we should still think about arrhythmias. So Dr. Choi and as other experts mentioned, but also we have seen a lot of people having a very high cholesterol who are having familial hypercholesterolemia. So those kind of population may develop silent ischemia from the cardiovascular coronary heart disease. Also, the other subset that has a sudden cardiac death is, I think, variant angina. I'm not so sure it's quite prevalent in your world, but in Korea, there are a lot of patients experiencing spastic variant angina in the early age, and that leads to certain cardiac deaths as well.
Thank you. A question for Dr. Seo. What is the safest age to do hybrid procedure for babies with hypoplastic left heart syndrome?
Baby?
Yeah, somebody said babies with hypoplastic left heart syndrome. If is there safe age to do hybrid procedure for this group?
Hybrid procedure is for atrial fibrillation in adults. So hypoplastic left heart, it is not yet applicable.
Yeah, okay. Okay, question. What is the heart disease most affected by COVID-19 in youth? I think very general question. Anybody can take that question? The most common
I think it's myocarditis is most affected, so that's most prevalent, and but usually it's self-resolving. So I think myocarditis is the best, the most cases.
Okay,
In the cardiac arrhythmia, and so one of the complication of COVID-19 and the ventricular arrhythmia is about 20% instance in the COVID-19 case.
Okay. Now, using heart rate variability testing during screening for sudden cardiac death, would it be beneficial?
One of the factor, one of the predictor. However, that is just we cannot use the one just only one heart rate variability is for the robust predictor for the sudden cardiac. That's just in the additive the factor.
Okay.
The currently the main robust predictor is the ejection fraction. And as you mentioned in the heart rate variability or the genetic testing and the MIVG testing and the late gathering enhancement is we can merge and the risk prediction, but just one is not the only one predictor to predict in the sudden cardiac death.
Thank you so much. A very interesting question. Is garlic really helpful for cardiac disorders? Garlic. Garlic ingestion. Some people think it's good for hypertension, but somebody is asking, do you have in Korea any experience in that regard? I don't think it's a very pertinent question to such highly scientific audience. But there are some anecdotal reports. I thought it's not in the mainstream medicine, so we can bypass that.
Yeah.
Okay, I guess I think we did very well, and I really want to thank you, all of you, for excellent presentation, excellent answer on important questions. I want to thank MCO for making this possible and getting us together on beautiful Friday. And we can go ahead and adjourn and enjoy the rest of the day. Thank you so much.
Thank you so much.
Thank you.
Thank you.